So my name is Olle Cate, and I'm from the Center of Research and Development of Education at University Medical Center, Utrecht in the Netherlands. What is a question we all have is, what is the ultimate goal of medical training? You could just imagine, just look at these people. It is that each of the physicians, residents, specialists, and that we graduate can be trusted to provide high quality, safe care. And the question is then, what is that? And it is safe care with a condition. We'll come back to that, with limited or no supervision. And if you think of what that actually means, just think of the legislation that many countries have. And as an example, I would go back to the Dutch legislation. The Dutch Medical Act actually says that people who have a medical license, this all doctors are entitled to perform medical tasks in general, but provided they are competent. So if you would be just a medical doctor, you would be legally actually entitled to start doing surgery, but no one would ever accept that because you're not trained as a surgeon. So I hear some noise in the background. Can people please mute because there's a lot of noise in the background. Okay. So provided they are competent. And then the next question is, of course, what is competence and how do we know that? Just think of this. Would you trust your loved ones with this trainee? Is a study that we actually are doing now, and this is the first publication, that we are interviewing program directors of anesthesia in Europe in different countries and ask them, can you remember that you signed off for a trainee that you actually didn't fully trust? What we found is actually that it is happening, and many people actually do remember that. They, residency program directors, and maybe also from medical school, can recollect cases of signing off for completion of training, even if they would not be fully confident. And you can ask, why would they actually do that? Why would they do that? Very often, this, what we sometimes call failure to fail, have different sorts of reasons. Like just simply they would say the time is up. So we're at the end of the time period, so that we must graduate these people. Or they would say we have no valid documentation to back up any failure. Or we are failing trainees, but if we do that, really that gives us a lot of trouble. So why not just graduate them and hope we'll never see them back? Or people say we just have no tools. We know exactly that this person is not adequate, but if they would sue us, we would probably lose that because we have no tools to handle it. We haven't backed that up. We have not documented that. And then they might add, when we are unsure, we'd rather err for the benefit of the trainee. And then implicitly, of course, not for the benefit of the patient. So the imperative of competency-based medical education is actually that we should not be satisfied with the situation, and we should try to reduce false positive decisions when graduating trainees for unsupervised practice. You don't want to graduate those people who might be dangerous for patient care. So we're at the topic of competency-based medical education. So what is that? Just briefly, of course, that's education aimed at a standard level of proficiency for all the graduates. And if we would work with CBME, and many countries like to do that, we need to have a clear description of standards for what is a good physician or what is a good specialist. And then assess all trainees using these standards and have competence and not time in training as a primary reason to finalize training. So then we have to define what is a good physician, but that's not very easy. So that is one of the reasons why it's not so easy to actually create valid workplace-based assessment procedures. It is, in the first place, difficult to define a good physician, and when we have defined that, to identify instruments or develop instruments to assess them. That's not easy either. And then to obtain, if we have those instruments, obtain reliable and reproducible scores that people will actually use when they evaluate learners in the workplace. So if you think of Miller's pyramid, and those who are familiar with medical education know this pyramid, it's pretty famous. And we would say, well, we actually approach the assessment of medical learners at 4 levels of different approaches of assessment. And we usually start in the bottom with looking whether they have knowledge or whether they can apply knowledge, and then whether they actually apply knowledge in a standardized like workplace-based simulation setting. And finally, also, we need to look at whether they actually act in real practice in the way we would hope they act. Now, we have standardized knowledge tests for the 2 lower levels of Miller's pyramid, and we can actually reach high levels of reliability. If we do that, we can create tests, we can extend tests as long as we want, and we can really make reliable tests that we know we make a difference between those who meet the standards and those who don't meet the standards. At the shows how level standardized skills tests, we can make them reliable. It's quite a bit of effort to do that, but we can do that. At the highest level, however, evaluation in the workplace, here finding reliable procedures is really a problem. So this we can do, that we can do, and here we are with difficulty. Just imagine, I'll give you one very simple example. Just imagine you are in a workplace, and anybody can just imagine, if you're a clinician or not a clinician, just imagine you have a learner in a workplace, and after a rotation, at the end of the rotation, your program director asks you, rate this person, rate this intern or clerk or whatever. And we'll make it easy for you. They would say, well, we'll break that down in 7 roles. And those 7 roles actually remind us of one of the famous competency frameworks, the Canadian CanMEDS frameworks, with medical expert, communicator, collaborator, leader, health advocate, scholar, and professional. All those things are important for physicians, is what we actually maintain all the time. And here's a 10-point scale from extremely low to exceptionally high, and just rate your intern at the end of the rotation. Recognize that, and recognize the difficulty you have in doing that. How would you actually know? And the longer we think of that, also in our literature, the longer we come to realize that it's very, very difficult to actually rate people on like separate competencies or separate domains of competence. 10 years ago, a literature review, Belluri, other people actually concluded that there's no evidence that the current measurement tools can actually assess those competencies independently. And they actually suggest that further efforts are unlikely to be successful, and they would recommend that competencies are perfect to guide and coordinate evaluations, but do that rather than develop instruments to suggest to measure precisely different competencies directly. Yet, what we do is keep on measuring competencies. That's what programs start to do. Here's some examples that, if you look at them, you become astonished. If we tell this to other people, they wouldn't believe it, actually. If you look at the variance of scores in workplace-based assessment, and the components of those variances explained by learners compared to the components of variance explained by the raters and other sources, should not make us be satisfied. These are just a simple few really recent papers that appeared in respectable journals, because the variance due to raters on scores measured don't exceed the 20%, whereas the variance due to raters actually is much higher. So if you have a student who gets a score, it's probably not more determined by the personality of the rater than by really the competence of the trainee. And that is a really troublesome thing that we have to work on that. So what makes reliable workplace-based assessment so difficult? there's different reasons. So just imagine there's a supervisor-trainee relationship, and that relationship might interfere with assessment. There is something that we recognize and call generosity error, high scores, or halo effects that are very prevalent in such circumstances. There is a range restriction of scores. If you look at the scores that people receive, and in the Netherlands, we are very used to a 10-point scale, and students, like I would say, the majority of students gets an 8 score of 8. If they have a 7, they feel that they have actually failed, or they really would like to get a 9, but the variance is very, very small. So it's a very narrow, I would say, Gaussian curve that you would see if you look at those. And that precludes discrimination among students. Some are better than others, but you don't see that on the scores. And then if you have a score in mind, if you are thinking as a clinician, I know what I think of this learner, and it may not be very favorable, and then just think of how you would convey that to the trainee. So that is a different story. So you have think something in mind, and then you have a conversation with the trainee. You find it difficult to actually give them a low score. So, and scores are context dependent. We have to realize that too. If you observe a learner, you are in one context, one occasion, so, but across occasions, there's differences. And as I said, there's rater dependency too. You have Hoxie, you have Dobbs, and all those ratings show low reliability. And just imagine that supervisors who they struggle with standards to compare with. You rate someone, sometimes you're like to rate related to proficiency, but that's not very easy. And sometimes you relate to personal development. You would say, for instance, this learner was at a very low level when this learner started, and after a few weeks, they really caught up very well. So you want to reward them for how they actually progressed in time, or you want to reward them for the effort, even if they're not terrific persons. Or you would say this person is not very good, but then if you would compare it to other people who have been rated before, they got high scores, so I can't stay behind with this one. So if you are a clinician, just think of this scenario. Your educational program director asks you to observe and provide feedback and report scores for learners under your supervision. When did you last assess a learner? Those clinicians who are listening now, just pause and think a few seconds and analyze your thinking. It might sound like this. Was the learner prepared? You don't know. You actually would like to know that. Or was the case easy or difficult? You can easily give a high score, but then you have to realize maybe this was a very easy case. So what actually does a perfect case execution look like? Is it the way that I do it? Or am I the perfect example? Or who should I compare that with? Or maybe you did find the performance pretty weak. And then you're thinking, how can you say that without hurting the learner's feelings? You must work with that learner tomorrow too. And you want to keep a reasonable working relationship. And what is a reasonable score on a 10-point scale? Is that a 5 or a 6 or a 7? Or maybe you think you actually very much like this learner, and you secretly think in yourself, you were the only observer, nobody else was there. So would it hurt if you would give that person a 7? While maybe in your heart you would think this is actually rather a 5, or all these conversations are so familiar. Everybody knows them. So why is individual assessment so difficult? You think of this learner, please mark me as superior, and you're going to mark that. And you think she's actually nice and she works hard. And then you start thinking maybe it will not hurt her and will probably motivate her. If I mark her as superior, then tomorrow she will even do more her best. So there's so many variables that come into assessment. So what is actually the purpose of that workplace assessment? Why actually we do that? It's maybe to confidently hand over a trainee to a next stage. You could say it could be a next clerkship or an internship, or the end of training, maybe for residency or fellowship, maybe for unsupervised practice. In other words, what you would like to do is entrust the learner with future care for patients and expecting a safe, high-quality patient care. So that's a very serious question, and it's actually quite different than the way people usually think when they rate learners in the workplace. But in this next phase, just imagine if in this next phase the trainee would not be trusted or would actually show serious failures. Would you have failed as an educator and an assessor? Or are you thinking, well, let's have this student graduate and I don't care what happens in the future, but that's not my business. I'm just a professor in a medical school. So we're just seeing what we observed and we don't really think about the future for this learner. Maybe that may not be the right way of thinking. So what can we do to improve our assessments? Assessment that matches the clinician thinking is important. I can refer to a publication by Crossley who actually says if you want reliable scores, at least you should ask the right questions. So a clinician can answer a question if the clinician is able to answer it. So if you get a good question, you get better answers. And if you actually can translate that, align in the construct of the clinician thinking, which is actually much related to patient care, to their assessment task, it might improve the performance of assessment skills in the workplace. So that would be matching the assessment to the clinician thinking to focus on entrustment of the learner with activities in healthcare, preferably in a holistic and not tick box way, and integrating but not separating different competencies. And at the same time, you also want a procedure that is practically feasible. I'll come back to that. So here's an example. Just think of a supervisor in anesthesiology. What is the most important question that is on the mind of the supervisor in anesthesiology? Basically, it's this one question: can I leave the operation theater? Can I leave the theater? Because here's my learner, here's the patient, here's the operation team, and they need anesthesia, and I can provide it, but my learner needs to provide it. So as the learner progresses, my main question is, can I leave that space? And how long can I leave that space? So Jennifer Weller actually created a skill that involves that idea of leaving the operation room. We call that now the Weller scale to assess anesthesia residents. And what she actually did is she took a well-known scale, which is called mini CEX, mini clinical evaluation exercise. That form has 9 scale values. And she made a copy of that, but with different scale values. She actually translated that. She has 3 components. One component is the trainee needs an assessor in the theater, so I cannot leave the theater. And the middle, and so the next stage would be the trainee needs an assessor in the hospital. So I can leave the operation theater, but I have to be there quickly if my help is needed. Or the third state would be this trainee actually could manage the patient independently. And if you look at the scale values that she actually created, or those 9-point scale, the more detailed values, it sounds like I'm not comfortable leaving, or like the next level would be I'm comfortable leaving for a brief cup of coffee, or then maybe for a bit longer, like eating your lunch, or I should remain in the premises, or I could even leave the hospital for a while, or I have to check in every once in a while, or I can just stay away, or you just can imagine, that's a skill. Basically, at that time, she didn't talk about the terminology of entrustment, but it is really an entrustment skill. It is a skill that leads to how much do I trust this learner to work on themselves. And she actually did that and compared that to the regular mini CX scale. And actually, it may not be perfect, but you could see that the variance due to the trainee increased from 9% to 21%. And the variance due to the raters actually decreased from 29 to 80%. So at least it's a big step forward to prevent a scale that they would seriously include. Actually, they include patient safety. It is not just observing the learner, are they doing something that I'm expecting they do, but their worry is about, will this patient be all right? Will this operation go all right? So here's where we come at the idea of entrustable professional activity. So just to remind for those who are not familiar with it, the definition of an EPA is a unit of professional practice. It's a task, or you could also think of it as a bundle of tasks that can be fully entrusted to a trainee once he or she has demonstrated the necessary competence to execute that activity unsupervised. That could be actually provide anesthesia during an operation. And the purpose of using those units is to operationalize competency-based medical education through a stepwise and safe engagement of trainees in clinical practice with progressive autonomy. And then if you would define what is competent, competent would be then actually that moment that you would think this learner is now ready to execute this activity unsupervised, to pass the thresholds that would allow for sufficient trust in the trainee to act unsupervised. So I have to observe the trainee as much as I can, and then at a certain point, I must be willing to take the risk to leave the operational room because I think the learner is ready to do so, or the learner at least knows exactly what to do when they are in trouble. They know how to call me, or I can just trust them to leave them alone, and they have to learn to be alone. So we need to do that at a certain point in training. So if you operationalize that idea of competence, it is when the professional activity is mastered at a threshold level that permits trust to act unsupervised. And that is a stage in a developmental continuum. This is what the continuum looks like. There's a growth of competence, and people would develop over time from a novice to an advanced beginner to being competent to being actually proficient, like doing things on speed, or being an expert at a high, very high level. And you could actually see that people develop, and if they keep on practicing deliberately that activity or whatever the profession is, they will still keep increasing. So at a certain point in that whole developmental continuum, you would have to be able to signify this is the moment where the student actually has completed training sufficiently to be working on their own, to work independently, or to be ready for unsupervised practice. And it's good to think of that as in the breadth, but you can think of that as for separate EPAs. So here's one EPA, and you could just think of that same graphic. But there might be another EPA that's actually easier. So at an earlier stage, you would come at a higher level. Or here's an EPA you have never started practicing until the second year of training. Or here's an even easier EPA. And if you draw that same line, that thresholds, that would permit you to make that decision for unsupervised practice. There's different moments in that training period. So some things may be easy enough, even though they are true contributions to healthcare, that you would say you don't have to wait until the end of training. We can qualify you as being able to do this alone, and we will not check on everything you did. We will just accept if you report on your findings or you would just perform a procedure, we just start trusting you, even though you have not completely completed your whole training yet. So there are different moments of justified entrustment decisions, and justified means we have observed you enough to make that decision. You might even think of a decision that was made because you have actually observed that the learner does this well. But if that's never practiced afterwards, maybe after a year or 2 years, you may not trust that person anymore. You may lose your trust in that person. Now, we made that distinction between unsupervised or supervised, but there is differences, and we already saw those differences in a scale of Weller. But a very simple framework that we use very often is a framework of 5 stages. So 5 levels of supervision, actually, that you could decide upon. So the first level of supervision is actually a level that there is only supervision. There is no no permission to act yet for an EPA, but there is permission for a person to be present in the healthcare space. You would never allow a regular person to be in an operation room, even though they're not allowed to do anything. But for a medical student, at a certain point in a clerkship or surgery, you would say, this is the first time we'll now allow you to be present and observe and not perform anything. The next level would be to whatever it is. It doesn't have to be in an operation room, but to practice an EPA. Could be at the bedside, could be in an outpatient clinic, to practice that EPA with direct or what we call proactive supervision. So the supervisor is present, can take over if needed, can provide guidelines at this point, can support the learner with directions and instructions, but need to be in the room. This proactive supervision. A critical next step would be to leave the room, and leave the theater, or leave the room where the consultation is, and just rely on the learner to actually call for help if help is needed. And that we call indirect supervision. So it's reactive supervision. And then there's that threshold that's important. That's a threshold that we could qualify as being competent. So now we would say, even you are alone, but we don't have to be in the hospital. We would even trust you now, even though we cannot provide directly help. If you need help, you'll have to solve things by yourself. That is a level of unsupervised practice. And then, of course, if you're very proficient and you have done this very often, you may start to be a supervisor for junior learners. So you start as a learner with observation only of a procedure or something that is in healthcare. Here's an example of actually a resident in gastroenterology doing an endoscopy. And in the back is a supervisor who actually can take over right away when things don't go right. This is a very critical procedure. People needed to do that under supervision for at least 200 times, many, many times, before they would be allowed to do that without direct supervision. And now here is an example of indirect supervision. So the learner has done something with the patient and reports later in the afternoon, for instance, or they could have called if they needed help. And then there's the fourth level, and learners at a certain point in time need to do things on themselves. This is maybe in a night shift. There is distant oversight. There is some supervision. You might be able to have a telephone call with the supervisor, but it is distant supervision. They might maximum provide you with some guidelines over the phone to do, but basically you are in charge now. And this, of course, is a level of supervision that you would provide supervision to a junior learner. Now, here is where that is translated in a program for an individualized curriculum for an individual. So this could be a portfolio of a trainee Jones. And in that portfolio, actually, all the EPAs of the program are actually mapped. And when you start with a learner, you might even suggest at which point in time would we actually expect you to be at that level 4 of unsupervised practice, or level 3 for indirect supervision. And that could be different moments for different EPAs. And it could also be different moments for different trainees. There might be a framework, like a template that you could use. And you might find that trainee Jones actually, as their education unfolds, you might adapt the moments where people actually reached level 4. And level 4 is a very critical decision that must be taken by a committee. And if you're not ready for it, you might do it later. But if you are very proficient, you might do it even earlier. So that is what we would call an individualized workplace curriculum based on EPAs. So this picture actually says postgraduate year 1, so that's postgraduate education. but something similar could also hold for the clinical phase of undergraduate education. So EPAs can be applied. They were actually originally designed to be applied in postgraduate training because it was important to think of when are people ready for unsupervised practice. And in our countries, like the Netherlands or most in the United States, people are, after medical school, only ready for supervised practice, like level 3. But in some other countries, that might be different. Now, if you look at this continuum and from bottom to top, you can just imagine that people come to medical school, they are trained in courses and simulation labs and get theoretical knowledge in early courses in the first years in the preclinical phase of medical school. And those elements of knowledge, skills, and attitudes actually are need to feed the background that's required for learners to actually acquire those EPAs or be trusted with those EPAs of end of training. So you would say in a preclinical phase that the supervision level might change from 1 to 2 in some cases, just move from classroom learning to doing things in the clinical space. And in the second half of medical school, usually people would move from 1 to 2, which is actually from being just present to do things under direct supervision or under indirect supervision. And for most of the EPAs in, for instance, our school in Utrecht, we would hope that people reach that level 3 of indirect supervision for many activities. And then you're ready to go to postgraduate training. And postgraduate training would definitely include new EPAs, but you could also have several smaller EPAs that nest into more broader, larger EPAs in postgraduate training, and you're being trained for that. And after the end of postgraduate training, you're ready for unsupervised practice. And then you're actually moving from level 4, which is allowed to do the things on yourself, to becoming a supervisor for junior learners. And maybe even for some EPAs, you could start doing that while you're still in postgraduate training. But now we know, and specifically if I'm talking to people in other continents, and I'm sure that happens in Colombia and other countries in South America, in Latin American countries, that many students go to unsupervised practice right after medical school. So that makes the definition of what the EPAs in undergraduate school are different in I would say countries like the Netherlands and North America from many other countries. I attended a conference last week in Pakistan, and I talked about the same things actually, about EPAs that lead to unsupervised practice in primary care rural areas where there's little supervision. So the way we look at our schools, we have to realize we have to train people to do things in critical situations with little supervision at the end of medical school. So to summarize, why are we using EPAs? So that is, if we think of a medical license, that could be the most broad and general EPA you can think of. We're actually stamping that we now trust the learner to be a medical doctor and to actually do whatever's needed for a medical doctor. But that is so broad that there's no individual teacher who, for an individual learner, really carefully be able to say, well, I know this person is ready. Nobody actually knows that. We don't know that in our schools. It is just too broad. So what we do with EPAs, we break that down in that breadth of a medical license into units of practice that can be overseen, assessed, monitored, documented, and certified. And if we think of competencies, and I'm not saying competencies should not be used, they are important, and people have to develop competencies, and we still will keep using that language too. But if you only look at competencies and you force people to rate competencies and assessments, they are often felt too remote from clinical duties to be optimal for assessment. And EPAs may be a better focus of assessment. Now, a regular assessment in the workplace, traditionally have done that, is not directly linked to individual progression of responsibility. And this is what we would do with EPAs all the time. Actually, we force people to think about, is this person ready for unsupervised practice? Even for general observations, we ask them to rate that and to make them actually ready for a summative entrustment decision. I'll come back to that. So competence development for EPAs who have to think and required supervision is something that is not only happening within a training period. So just remember these graphics, and I added some to them. If you look at them, and you have a slightly different approach, and the different approaches, we're talking about like theoretical stages of development, but we're now looking very practically at decisions that are made for autonomy. So at the left side, now you see direct supervision, indirect supervision, supervised, unsupervised practice, and being a supervisor. And you could see that for different EPAs, you can just imagine that you would have moments that people are ready for unsupervised practice for different EPAs, as I said. But there could also be EPAs that either take the yellow one, you are in training, you have not reached that level of unsupervised practice, but your training is over, and you are, it will take you maybe another year before you are really ready for unsupervised practice. And you can also imagine that after training, there's new things because healthcare changes all the time. So there might be new things that you have to be trained for before you should be allowed to do that with unsupervised practice. Now, I also actually signified those moments of indirect supervision. And so you just imagine that there are moments for indirect supervision. So the yellow one has that level of indirect supervision. You might say, well, in this case, we will allow you to graduate, but we will stipulate in your portfolio or whatever implicitly in your license that we don't expect you to do this unsupervised. You may do it, but only if there is a more experienced supervisor in the vicinity. So you have to think about this, and it's interesting that we are doing studies specifically, for instance, in veterinary medicine. I have one of my PhD students who just graduated last year did a study and published a paper with a title called "Qualified, but Not Yet Fully Competent." And that's what happens specifically in veterinary medicine, because most people don't go to postgraduate training, and they are suddenly allowed and supposed to be doing things that they don't feel comfortable with. And now, so in veterinary medicine, there is supervision that must be provided in the first years of practice, because it's just not safe for those nearly just graduated veterinarians to do this in practice. But we might also think, should we also apply this in medicine? So so come back to assessment. So why do EPAs change workplace-based assessment? So because the core question of assessment for entrustment is not so much determining the point on a scale of proficiency that matches the learner best, but it's considering a decision to increase autonomy. So that is not the same thing. It is actually a focus that is much more linked to the quality of patient care. Just think of education. So traditionally in education, we have a retrospective approach to assessment. So much of education, specifically outside domains like healthcare, just in all sorts of education, you give courses and you just give tests, and you are provide expectations, and when the students meet those expectations, you give them a high score and they can graduate. So the question then is always, has the student mastered the content taught in the courses and rotations? If they did that, they can graduate and they get a high score, and we're not concerned about what they will do in professional life. That's not our business. Oh, just wait a second. Here, stop and pause. This is not responsible medical education. We should be actually concerned about what people do in the future. So that is a prospective approach to assessment. And the prospective approach really is the student ready to assume the expected future responsibilities? we're delivering students with a license that are going to do that. If they don't perform well, we should be concerned about what did we do wrong? Why did we assess people do? So if you just make that to the micro situation of this conversation, and you have the psychology now of EPA-based workplace assessment, the same student might ask or might think by themselves, mark me as superior, and then you would think she's nice and works hard, but it may hurt my patients if I now mark her as ready for unsupervised practice. I just don't want to leave the room yet. So that's independent whether you like the person or not, but your patient is so important. You can't leave that patient alone with this patient, with his student. So here's where the trust concept comes into the assessment. So we have to realize that trusting someone is making yourself vulnerable. It's your patients. If you leave that student alone with your patient, you're making yourself vulnerable. So you, at a certain point in training, you have to accept the risks that adverse events could happen. But you just have to train your student well enough that you are willing to accept those risks. And have to realize that graduates will be certified for activities you may not even have observed, or even stronger, the learners may never have not even encountered. And just to give the example of the veterinarians, when I talked to my PhD student, she said, well, I'm like farm animal veterinarian, and I'm supposed to do cesarean sections on a cow. And I've seen how that works with that's a huge skill that you have to be able to do. And then she said, you're lucky in undergraduate school if you have done that twice. But some people, our graduate, have never done the section. And then they come and start working as a veterinarian for farm animals, and they suddenly have to do that. So I wouldn't say that would be very typical, and we have to be careful about that. But even in the detailed level, you know that your learners will encounter situations they have never seen in practice, and you have to trust them. So basically, the entrustment decision requires an estimation of their adaptive competence to cope with unfamiliar situations. And trust involves more than the average of past performance. So it's more than that. Just think of two learners here. There's learner one and learner two.
Hello?
And hello? Yes. Can you mute your microphone? Is that okay? So who would you rely on for the next patient? Here, look back at those two learners across 10 observations. If you average out, this is a scale that actually runs from -10 to +10, and the benchmark would be a 0 level. And you can see that learner one actually has a higher average score than learner two, 2.1 versus 1.9. Another question is, who would you trust to take care of the next patient? Just look at these. Would you agree that would probably be the orange learner, learner two? They never actually failed below 0. And even they have an average score that's lower. And that is why it's not just a simple way of looking at average scores, for instance. It is really the question that you have all the time is, can I trust this student to this patient now? So what factors determine trust decisions? This is an ad hoc decision. So you are at this moment, you need to ask yourself the question, can I leave the room and have that student take care of that patient? It is more than only knowledge, skills, and specific proficiency. There's an ad hoc decision. And all these elements, can I trust this student to attend to this patient now? That's all what goes to your mind as a clinician. So there's factors that are determined by the trainee, by the supervisor, by the task, by the context, and by the relationship. We know that from the literature, there's those 5 components. And just think of the trainee. There are elements like integrity, reliability, humility, capability, and agency. I'll come back to explain that. But there's also supervisor elements. So we know that supervisors differ. And depending on the clinical experience, their trust propensity, their supervisor experiences, there's task difficulties and task risk involved. So that also comes into the equation. And then there's a context. So is there a qualified nurse around who could help if I'm not there? Or what is the time of the day? Or is it in a night shift? Or it might be so that we might need just the hands because they're so busy now. We need that student to take care of the patients. Or could also be what is the culture in our department, or do I know the student well? What is the duration of the acquaintance with the student before I take that decision? It's all important. Now, here are those general qualities of trainees. We know it's not just proficiency. It, of course, that is, or capability, that's important. It's knowledge and skills and specific experience and awareness and oversight, but there's more things. It is also integrity. Is this learner truthful? Does this learner have good intentions? Can I really trust this person because the person is benevolent and patient-centered? Or is this student reliable? Is this a student who is conscientious, predictable in their behavior, accountable, responsible? Just remember the graph that I showed of those two students before. And the one student is much more predictable in their behavior than the other student. And then there's humility. Will this student observe their own limitations? Will they ask for help if they really need help? Will they be receptive to feedback? That is important before you want to make an entrustment decision. And there must also be agency. Is this student sufficiently self-confident? Will they be proactive? Will they take initiative if they need to take initiative towards work, towards team collaboration, towards patient safety, towards their own development? So those components are derived from the literature. We have actually reviewed 10 studies that were all focused on the question, what does it take for a clinician to trust a student? And we came up with those 5 elements. And if you juggle the words around a little bit, take the first letters, there's an acronym that you will be able to remember. Just think of a rich entrustment decision. So we talked about those decisions and made, I mentioned ad hoc decisions, but there's also summative entrustment decisions. So ad hoc are those decisions that you make on the spot. You're not promising that the student will be able to do things tomorrow alone, but just now because you all take the context into account. Now, a summative decision is actually more a certification and are based on multiple workplace-based assessment. It must lead to an increased autonomy in general. We sometimes call that a STAR, a Statement of Award Responsibility. From tomorrow on, we will allow you for this EPA to be working on indirect supervision, and we're willing to sign for that. So if you look at the flow of workplace-based assessment, what happens, you have those ad hoc entrustment decisions that you would take with an EPA. You would observe the learner or have a debrief directly after. We'll evaluate the learner, provide feedback, and say you could try it tomorrow, and we'll see that a few times. If you have done that a few times well, you might be ready for a summative entrustment decision. We will document everything that we have observed in your portfolio every time. And then the request goes to the Clinical Competency Committee, sometimes called an Entrustment Committee, receives that, evaluates that request, looks at the portfolio data, and might take that decision, say, now you are ready. You actually may even meet the objectives for the end of training, but you're still early. But we can give you that start. From now on, we will allow you to work with indirect supervision. So there's a lot of programs that start using this whole model. I would have liked to show you how that works. I don't have that at hand for medical training, but I have a very nice 3-minute video or animation actually that shows how that works in dentistry. In dentistry, they use this model too in the Netherlands, in Nijmegen. So this is a 3-minute video you can see.
This is Emma, a 23-year-old dental student. She's now in the 2nd year of the dental master program of the Radboud University, Nijmegen. Twice a week, Emma works in the SRDC, where most of the clinical work in the master curriculum takes place. At the start of the day in the SRDC, Emma and her team arrive in the SDC for the briefing. The briefing is chaired by one of the students. After the briefing, Emma chooses the EPA she's going to work on today. Here we see Emma treating her patient, supervised by an experienced supervisor. At the same time, about 10 fellow students treat their own patient, also supervised by the supervisor. Emma and the supervisor discuss the treatment of the patient, and the supervisor gives Emma feedback. At the end of the morning, Emma completes a digital EPA form. She reflects on technical aspects and professional behavior during the treatment of one particular patient. Emma sends her completed EPA form digitally to her supervisor. The supervisor opens the EPA form and reads the self-assessment of Emma. After that, Emma and the supervisor discuss the EPA form. The supervisor completes the EPA form with additional feedback. Here we see the self-assessment of Emma, including the feedback of her supervisor. The supervisor and Emma complete the EPA form, and the supervisor closes the scoring program. Using EPAs, students are gradually entrusted based on the work they have been showing in the past practicums and the trust supervisors give them for the future. During their years in the SRDC, students build up an extensive portfolio of EPAs, including self-assessment and assessments by supervisors. Both students and supervisors can see all EPA forms and feedback at any time. Here we see the so-called dashboard that gives an extensive overview of the portfolio of the students, both on group level and individual level. In total, after 3 years of participating in the SRDC, Emma has approximately 240 completed EPA forms in her portfolio. After 3 years in the master program and in the SRDC, Emma graduates. Her extensive portfolio now is a good starting point for the rest of her career, since she can use her past experiences to build onto and to become a lifelong learner. For more information, contact Radboud UMC University Medical Center, Dentistry.
So what you, some people start asking, so that looks like something that is very, very extensively actually burdening our clinical faculty. We cannot do that because it takes too much time for people to do it. Now we can see that we are actually moving towards a situation that we use mobile apps actually for EPAs. So several firms and institutions actually developed mobile technology to do that. And then assessment and feedback may not take more than like a minute or maybe 2 minutes. One example is an app that was created in Switzerland called Prepared, used in EPA-based anesthesia training, completing those assessments by the person self and also by the supervisor. That increased for happenings that were just a few times per year to now every day. This is another 40-second video clip that you can see how it works. So here's the learner actually pulling up the EPA.
Wenn die Assistenzärztin die Tätigkeit ausgewählt hat, erscheint ein einmaliger QR-Code, der vom Oberarzt in 2 Klicks gescannt wird. Die nächsten Schritte laufen auf beiden Smartphones synchronisiert ab. Unabhängig voneinander schätzen nun die Assistenzärztin und der Oberarzt zuerst die Komplexität der gerade gemeinsam erlebten Situation ein und danach, wie viel Supervision die Assistentin gebraucht hätte. Das Kompetenzprofil kann von Arbeitsstelle zu Arbeitsstelle mitgenommen werden, damit man gleich vorweisen kann, was man schon erreicht hat.
So that was very, very short. I would say it takes 40 seconds, but it's really very short that you start doing that. So here is and it gives a much more basis for a clinical competency committee to make summative entrustment decisions. Now, I want to close with a few things, a little word on objectivity and subjectivity, because people start asking about that a lot. So what we think is, so many people think that it is very subjective what happens in the clinical workplace, and we should make that objective as possible. But we have to realize that objective assessments are just quantified judgment, and we call them objective, but basically they're not much more than what we think about a learner. And we have to realize, as several publications in the past times actually, that we can use that idea of expert judgment being actually subjective, because it's there's no other way. That's almost the definition of expert judgment. So the enrichment of judgments of learners cannot be fully captured in assessment form. So what you need to do, because you want to establish fairness in workplace-based assessments, you want to minimize undue bias. So what clinical competency committees need to do is to pull subjective experience from different people to arrive at an intersubjective or shared judgment and combine that with objective portfolio data. And then actually what we are doing is actually making those decisions, and we come back to Miller's pyramid, because we have to ask ourselves, is reporting what a learner does at the highest level really the highest level of assessment? And if we think of it, it's basically, it is not only does, but actually trusting them for the future. So at the lowest levels, knowledge, we want to assess knowledge. We want to integrate knowledge and skills here. We want to assess integrated in the real life context, but we also want to make an inference or an estimation of readiness for future demands. So to finalize with some take-home messages, traditional psychometric approaches to assessment in the clinical workplace, like reliability, are problematic. How good is the trainee? A decision to increase autonomy for a health care task provides a better benchmark for reliable judgment. And weighing the risks of autonomy, can I trust the trainee, requires a deeper and sometimes even braver evaluation than judging just observed performance. Rich entrustment decisions require acquaintance with the trainee, and external examiners will miss out essential data. If you would, sometimes we could say, well, we should have external examiners, but they miss out important information. And not all judgment can be captured in words and forms. The richness of subjective judgment may get lost when confined to items on a rating form only. And defensible summative entrustment decisions require an accumulation of multiple observations by multiple observers in various settings. And clinical competency committees must combine intersubjective judgment with portfolio data for valid decisions. And observations should happen in the routine of clinical work. Technology is now making that possible. Thank you very much for the attention.
Thank you, Professor. We have one question. When a resident of in a specific EPA, how to translate the EPA to a medical remediation program? When and how to decide it is enough to approve or to definitely fail?
Yeah, can you repeat that once more, because I missed some of that.
It's also a questions and answers column. When a resident or specific EPA, how to translate the EPA to a medical remediation program? When and how to decide it is enough to approve or to definitely fail the student?
Okay, so yes, that's a very good question. Actually, what you're thinking of, let me start thinking that every student should fail at an early stage, because that's the nature of education. We are educated because people cannot do things, and there are first times that people start doing things. We have to accept that they will not always be perfect from the beginning. So then the question is, how long will you train a student until you would decide this does not make sense? So we have to fail the student because we're not giving more opportunities for practice. Because if the student needs more opportunities, that's the first thought you would have, that give them more opportunities to practice, and we'll just see whether they actually increase their skill. So, but at a certain point, then you have to make a decision. Well, maybe that student should really fail. And by documenting that, it's easier to do that and easier to explain to others that you have done that. And so it's interesting to think, a topic that I did not touch upon here is that is very heavily discussed now in medical education is time variability. So should you allow for more time in training if people are slower? From the perspective of mastery learning, we know that actually Some people would maintain that everybody can reach everything. I think that's exaggerated, but there might be possibilities to increase the training length a little bit to allow people to actually meet those standards. And and now people start asking, how far can you stretch that actually or not? And we are publishing a paper actually now where we suggest, but it's just a suggestion, it's not really evidence-based, but you think of something like no more or less than 20% variability in training length. And then you should take a decision if the trainee would need more than 20% of the time, like if you have a 4-year program, you might not want to go on for 6 or 7 years because that is just too much. Then you would have to decide this student should not be in this place. This student is never going to reach that end. It is difficult to give a pinpoint an exact point for everyone. It might be different, but it's much more clear if you have documentation. It's much easier actually to say this student should actually fail, and we cannot accept to keep that person in training.